Hello?
Yeah, we are in live. 1 second.
Okay, doctor has to start it from first.
Yeah,
No?
we have not started. No, we can start from first.
Oh, it has not been started yet.
Yeah, no, not yet started.
Actually, she had already 20 slides have already presented.
No, the doctor has went out. So we can start now from the beginning, or you need to start from the in between. So it is better to start from the first slide, ma'am.
Starting slide start करें. Start करें.
Yeah.
Start करें. बस introduce करें.
Yeah, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare. Welcome to all for the today's webinar. The topic for today's webinar is examining the uterus, cervix, and the endometrium. I welcome all the participants who was joined today. I request them to post their queries, if any, in the chat box so that we can have a short QA session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Ranjana Bhandari, ma'am. Madam has done her MD OG, and Madam has asked vast experience in this OG division. And Madam is currently the Additional Director and District Health Quarter Hospital, Mayurbhanj, Odisha. So with this short introduction, I welcome you, ma'am. Over to you, ma'am.
Hello, am I audible today?
Yes, very much.
So, good afternoon, everyone. So, my topic today is examining the uterus, specifically the cervix and endometrium.
You can click on the slide and you can just go to the yes.
So the learning objectives today are, at the end of the lecture, we will be able to recognize the typical ultrasound appearance of normal cervix and endometrium, and then differentiate it from the abnormalities. So the key points will be, at the end, you will know the difference between typical ultrasound features of normal cervix and endometrium and the abnormalities in the cervix and endometrium. And in that case, at the also find out if the patient is in a doubtful state, for example, in malignancy, we can refer it to a higher center. As we know, the ultrasound of endometrium and cervix is better seen by transvaginal scanning, but we can do transabdominal scanning during cases of unmarried ladies, when the uterus is very big, like big fibroid or globally enlarged endometriotic uterus, or gross ascites, or if there is a large mass in the POD. But that is by transabdominal scan. Today I'll be speaking about transvaginal scan. In the transvaginal scan, as you are seeing the black structure, which in the right see, the screen is in front of you. You think a man is in front of, or a human being in front of you, and the right side of human being is left side of the viewer. And in the screen, I'll be speaking only about the patient's right side or left side. So patient's bladder is towards right side of the screen, and patient's rectum is towards left side. So all the anterior structures are depicted on the right side, and the posterior structures are depicted on the left side. Then upper and lower part. Upper part of the screen is showing the cervix, and the urethra, and the lower part of the screen is showing the rectum, bladder, and fundus. So all the inferior structures are seen in upper part. All the superior structures are seen in the lower part. Am I audible?
Ma'am, yes, ma'am, you are audible, ma'am. You are audible, ma'am. Yes.
Thank you. So now this is a video. I am not able to show it in this slide, but in the left side you are seeing a little bit of this urinary bladder, and just posterior to urinary bladder is the uterus with the thin echogenic endometrial lining. During TVS probe, when we enter into the vaginal cavity, we should look for any pathology in the vagina, for example, Gartner cyst or a endometriotic nodule. Endometriotic nodule are the hypoechoic structures which can be seen in between vagina and rectum during rectal endometriosis, or anteriorly between urinary bladder and vagina in case of bladder endometriosis. So now my part is cervix. Now what do you mean by cervix? It's the lower portion of the uterus extending from internal os to external os and consisting of endocervix and cervical stroma. The ectocervical part of the cervix is covered by squamous epithelium and the endocervical part is covered by columnar epithelium. The cervical findings are, in the first image, you are seeing a thin lining of cervical mucus. The thin lining of cervical mucus occurs during peri-ovulatory phase as the mucin and glycogen is secreted from the endocervical part of the cervix. So this is the time when during reproductive IVF or IUI, we are giving HCG injection. The second is the chronic cervicitis. See the lower portion, we are seeing echogenic focus, and still in them also there are some anechoic watery structure, which is the mucin secreted from that. The third finding is the Nabothian follicles. They are very common and physiological findings. They are the mucus filled cyst on surface of cervix. They are caused by squamous epithelium of the ectocervix growing over the columnar epithelium so that they block the cervical glands. And then on the ultrasound, they are of varying size, for example, from 2 to 20 millimeter. They can be seen in the ectocervix or endocervix near the cervical stroma. On the ultrasound, they appear anechoic, means all the sound waves passes through it, and avascular on Doppler ultrasound, as you are seeing in the last image. Now, in this image also, you can see some endocervical Nabothian cyst throughout the endocervical canal. Then comes cervical polyps. Cervical polyps are sessile or pedunculated, well circumscribed masses within the endocervical canal. They may be hypoechoic or hyperechoic. Due to the stalk with a feeding vessel, we are able to locate whether the polyps are endocervical in nature or endometrial in nature. Now comes cervical cancer. So cervical cancer is very common, and they are the heterogeneous masses involving the cervix. It may show normally shows increased vascularity on color Doppler due to neovascularization in the carcinomatous structure. By ultrasound, we can find out if it is a low risk or high risk cases by seeing the size, if it is less than 4 centimeter or more than 4 centimeter, by parametrial invasion or tumor invasion into vagina or adjacent structures like bladder or rectum. In the stage 3B or 4, we can also find out by transabdominally the hydronephrosis affecting the kidneys or metastasis in liver or presence of lymphadenopathy with periaortic nodes or obturator nodes, pelvic nodes. So this is now my cervical portion is over. Now comes the endometrium. This is the endometrium in the center of the uterus, which is seen in a secretory stage. Because the endometrium differs between reproductive phases and postmenopausal. The changes occur throughout the menstrual cycle in reproductive females under the influence of estrogen and progesterone. See, we are seeing the endometrial changes, but let us see it in comparison with the ovaries. Shortly after menstruation, when there are very small follicles all throughout in the ovary, we are seeing a thin lining of the endometrium because only two basilis layer, 2 millimeter layer, they are opposed to each other. But in a proliferative phase, that is 3 days before ovulation, see in ovary we are seeing a big follicle, and it, because of the estradiol secreted by it, we are seeing a trilaminar view of the endometrium. How can you find trilaminar view? In the center we are seeing a submucosa. Just outside it there are 2 layers of hypoechoic structure that shows the functional layer of endometrium, and surrounding it is the hyperechoic or white color region, that is basilis layer. But the endometrium, so this is trilaminar view. Now the third figure we are seeing proliferative phase 1 day before ovulation. The trilaminar view is very normal in appearance. In the fourth state we are seeing secretory phase 6 days after ovulation. So in the lower portion we are seeing corpus luteum cyst, and in the upper portion we are seeing secretory phase. It becomes homogeneous and hyperechoic homogeneous. Why? Because the mucin and the glycogen secreted from the functional layer is now making it white color. So how to measure endometrial thickness? The IETA or International Endometrial Tumor Analysis has categorized the measurement of endometrial thickness in mid-sagittal plane. It should be in the widest part. At the time of measuring the thickness, the whole endometrium from fundus to be seen till cervix, it should be perpendicular to the midline. Now, how to measure the endometrial thickness if there is fluid within it? When the fluid is there, we have to measure the endometrial thickness separately, anterior layer and posterior layer, and then add it up. If there is a lesion within the endometrial cavity, then if the lesion is endometrial in nature, then we have to add it. But if the lesion is myometrial in nature, we have to again find out the endometrial thickness separately, anterior layer and posterior layer, and sum it up and give the endometrial thickness. The average endometrial measurement is in the menstrual phase 2 to 4 millimeter, proliferative phase 4 to 8 millimeter, in the late proliferative phase 4 to 8 millimeter, and secretory phase 7 to 14 millimeter. We should remember that in the proliferative phase, the endometrial thickness increases by 0.5 millimeter per day, but in the secretory phase, it increases by 0.1 millimeter per day. So this is a video. I'm not able to show you the video. We are seeing in the endometrial phases, different endometrial phases of uterus. Now comes the endometrium in the postmenopausal women. This is also very important. In the postmenopausal women, the thickness should not be more. If the thickness, some studies say 4 millimeter and some say 5 millimeter. But if the thickness is more than 5 millimeter, that is not all the time pathological, because these days we are giving hormone replacement therapy, and some ladies of breast cancer, they are taking tamoxifen. That also increases the thickness along with inhomogeneous and cystic endometrial hyperplasia. But still the thickness is more than 5 millimeter, we should evaluate a patient. So this is another view of postmenopausal women. I'm not able to show the video in this. So the IETA says there is endometrial thickness, and after that we have to describe the endometrium in the echogenicity. Now the echogenicity of the endometrium is always in comparison with the myometrium. If the echogenicity is lesser than myometrium, then it is known as hypoechoic. If it is similar, see in the second figure, it is similar, then it is known as isoechoic. And if it is more, that is hyperechoic endometrium, then normally which occurs in the secretory phase. Another finding is endometrial-myometrial junction. The endometrium-myometrial junction is regular. See in the first picture, it is regular. If there is some cancer and not defined, then we are saying it to be irregular as seen in the second figure. And if it is interrupted by some myomatous polyp or any submucosal myoma, then it is known as interrupted. The IETA consensus statement describe endometrium first as in the how to know the thickness, then endometrial echogenicity, as I told, hypoechoic, isoechoic and hyperechoic, endometrial midline. Again, I will show you. See in this figure, the uppermost figure, we are seeing, and there is a single lining of hyperechoic or echogenic area, that is the mucosa. If there is any polyp or endometrial cancer, this line is interrupted. So this is the midline. Third is endometrial-myometrial junction, that we will study during cancer. It gets disrupted. And if there is fluid in the cavity, I told you how to see the fluid. The fluid echogenicity has to be seen. I will show you again. And the endometrial outline has to be seen. The intracavitary lesion of an endometrium, it may be pedunculated or sessile or both, depending upon the diameter of the base and comparison with the diameter of the maximum diameter of the lesion. If the diameter of base is smaller than the diameter of lesion, it is pedunculated. And if the diameter of base is more than the diameter of the lesion, it is sessile lesion. The color and power Doppler I will tell you in my next slides. So how to describe the intracavitary lesions? It is all subjective assessment. We are not measuring the percentage and all. So the endometrial lesion are arising from, first we have to find out if the lesion is arising from endometrium or myometrium. The endometrial lesion, how much surface it is covered. If the surface covered is less than 25%, we tell it to be a localized lesion. And if it is more than 25%, we call it a extended lesion. Again, the echogenicity, uniform or non-uniform, the outline, irregular or regular, and color Doppler, I'll tell you in next session. The degree of protrusion into the cavity in case of myoma. Because proportion of myoma protruding into the uterine cavity seen at sonohysterography, or when there is pre-existing fluid in the uterine cavity, for example, during menstrual phase, if it is 100% protruded into the endometrial cavity, it is known as grade 0. If it is more than 50% protruded into the cavity, it is known as grade 1. And the lesion is, if the myoma is less than 50% protruding, it is grade 2. This we have to do grading in order to have, we can do the hysteroscopic resection or not. Now, how to measure intracavitary lesions? As in all other cases, all the intracavitary lesions have to be measured in 3 orthogonal planes, that is longitudinal, anterior posterior, and width, by doing transverse scanning. There are some common endometrial pathology. First and foremost is endometritis. See, in this picture, you are seeing echogenic irregular endometrium because of endometritis. There may be presence of fluid. There may be sometimes inflammation occurs in such a manner that even calcified plaques can be seen. Or sometimes gas-forming organism produces gas within the endometrial cavity. The second is polyps. The typical ultrasound features of endometrial polyps are bright edges. Why bright? Because it is the interface between the outer layer of the polyp and the uterine endometrial cavity. See, in the second post, you are seeing it is hyper-echogenic. Then in the third, on the right side, you are seeing regular cyst. And then on putting a Doppler, we are seeing a feeding vessel. In the central image, we are seeing difference between myomatous polyp and endometrious polyp, because myoma can also protrude into the endometrial polyp. But myoma is always hypoechoic, whereas endometrial polyp is hyperechoic. Myoma is always covered with endometrium, and it is normally having peripheral vascularization, whereas in a case of polyp, there is a feeding vessel, single vessel. So this we can see the feeding vessel within the endometrial polyp. This is another endometrial polyp, just in the lower end near cervix. can see a small black area. By sliding the polyp against by sliding our probe in the posterior or anterior vaginal wall, we can see the sliding of polyp in the endometrial cavity. So these are the typical ultrasound features of submucous myoma. It's solid tumor protruding into the uterine cavity. The echogenicity is similar to myometrium, and the colored Doppler shows a ring of fire, not a feeding vessel like polyp. Now, if there is intracavitary fluid, we have to measure it in 3 perpendicular diameters. Amount of intracavitary fluid is defined by its largest measurement in the sagittal plane. It is also defined by anechoic, means without any echo within it, ground glass if there are fine echoes within it, or mixed echogenicity due to maybe blood or RPOC when it is hyper as well as hypoechoic. Now this is a slide of RPOC, retained product of conception, just after delivery, normal delivery or cesarean or incomplete abortion. We can see hyper and hypoechoic structure within the endometrial cavity. But on putting Doppler, we can see there is vascular supply within it. That is why this is a case of RPOC. In the next phase, you are seeing one endometrial cavity. If the patient came in the postpartum state after normal delivery, but there was lot of bleeding. So when we put the ultrasound, we saw echogenic contents within the endometrial cavity, but on Doppler, no supply in. This was only blood clot, and we don't have to do anything. We have to just wait for conservative treatment. In the third figure, we are seeing AVM or arteriovenous malformation. This occurs more in cases of near myometrium. Lot of bleeding occurs if you do DNC in such cases. In these cases, we have to do conservative management up to 4 to 6 months, and then it disappears. And the pregnancy test will be negative in this AVM. Now comes molar pregnancy. In the molar pregnancy, we see lot of anechoic and hyperechoic structures within the uterine cavity. It may be partial mole or complete mole. In case of partial mole, as seen in the left figure, we are seeing a small fetus along with placenta, which is having, see, in the second figure, you are seeing normal placenta, and part of it is having partial molar pregnancy. This was a case of twin pregnancy with one fetus alive having normal placenta, and the second fetus was dead with molar placenta. In the next figure, we are seeing invasive mole. Invasive mole is a type of cancer in which the whole uterus is covered by endometrial cavity is filled with anechoic and hyperechoic structure having lot of splashes or color Doppler within it, lacunar type. Even the myometrium becomes thin in thickness. Now come to endometrial cancer. Endometrial cancer, in that the endometrium becomes thick, irregular, inhomogeneous, richly vascularized on color Doppler. See, in the second figure also, we are seeing endometrium thickened, irregular, inhomogeneous, and there may be some pyometra or hematometra within it. How to do power Doppler or color Doppler in gynecology? We ensure color and power Doppler box includes endometrium with the surrounding myometrium. The magnification should be very well set up. The frequency should be more than at least 5 megahertz. The PRF, that is pulse repetition frequency, should be adjusted to 0.3 to 0.6 as the vascular supply is very low. So if we do the PRF 1, we will not be able to see any vascular supply in the structure. The wall filter should be adjusted to 30 to 50 megahertz. 30 to 50 hertz only, sorry. So this is Doppler ultrasound examination of the endometrium. There are 4 color scores have been given by IETA. Color score 1 shows no color. Color score 2 shows minimal color. Color score 3 is the moderate color. And color score 4 is abundant color. But we have to adjust the settings at 0.3 to 0.6 only kilohertz to see all this type of color scoring. Now, there are some benefits of fluid instillation, that is known as saline infusion sonography. See, when we do saline infiltration of endometrial cavity by some catheter, we are seeing the polyp and the endometrium do properly in the structure. Another important figure is intrauterine adhesions. If we do after, this is seen after some DNC, DNE, or even normal delivery or myomectomy, that there are some fibrous echogenic bands which obliterate either partially or completely the whole endometrium. And that time the functional endometrium secretes some fluid as seen in the right side of the figure, and the partial, if it is totally obliterated, then we cannot see, they don't undergo any menstruation and the patient becomes amenorrhea. See, again you are seeing a strip lesion in between the two functional layers. The arrow shows the strip lesion. See, again in the next it is showing the strip lesion, and in the lower it is completely obliterated. The whole endometrial cavity is obliterated. You can also see the correct position of copper IUCD in cases of ultrasound. See this ultrasound first figure, the IUCD is in the top position near fundus, so it is normal position, which on the transfer scan will show a single point. In case of hormonal IUCD, the manufacturer puts echogenic material in the upper end. So you can see the upper end, and the whole shaft will produce a shadow, which you can find out in the transverse view. But normally, 3D is a very good, shows very good placement of property. This shows the incorrect position. See, now we are seeing the IUCD in the isthmus and the cervical canal. In the lower part also, it is in the cervical canal. In this part again, it is in the cervical canal. And the last figure I saw 1 year after cesarean, the lower part of IUCD was towards cervical scar, towards the LSCS scar. So this was a malposition. So missed property thread, we should do ultrasound. Now another important figure is hydrometrocolpus. This occurs when there is imperforate hernia hymen, or if it is a case of vaginal atresia. This we can find out. See the whole fluid, the menstrual cycle, the patient will be having cyclical menorrhea, pain in the abdomen, and amenorrhea. So we can find out by ultrasound there is full of blood or anechoic area within the endometrial cavity, endocervical cavity, and vagina. This is a case of subseptate uterus. Even congenital anomalies can be found out by ultrasound, but it has to be confirmed either by 3D or MRI. In the broader, we see the transverse scan. There is a broad fundus. There can be two cavities near fundus, which are more seen during secretory phase. So the key points are, we should use a standardized terminology when we describe the ultrasound images of endometrium and cervical uterine cavity, and that is known as International Endometrial Tumor Analysis. And which patient should we refer? We should refer the patient if we are in any doubt, especially if we suspect the case to be a malignancy one. Thanks a lot. Now, if there is any question, please ask.
Thank you, ma'am. Thank you again, once again, for that wonderful and detailed presentation, ma'am. Yes, ma'am. Let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read it for you, ma'am.
Thank you. Thank you.
Again, once again, ma'am, that was a wonderful presentation, ma'am. The pictures which you showed and the videos that were unable to play, ma'am. So if you could have played that video, then it would be a better presentation today, ma'am. But of course, ma'am, that slides which you have shown was very clear, and it was very impressive, ma'am. Audience, if you have any queries, you can just post it to the madam so that I can take it to madam. So you are welcome for queries. Ma'am, there are new advancement when it comes to this ultrasound, ma'am. There are Doppler 3D. So what are the advantages, ma'am? Like whether a basic scanning is enough, or the advancement of new things like Doppler and 3D is better? And is there any advantage, ma'am, in doing this test, ma'am?
See, one very important thing is we Indians are not so rich. So in the poor conditions, the TVS is the best. It cost only 1,000, within 1,000 rupees we take. So it is the best. But then if one can do, if one can afford, then 3D, 4D, or best is MRI. In cases of septate congenital anomalies, we have to do MRI in order to find out the structure. So best is
Okay.
MRI. 4D, 3D are very, very good. But because they cost a lot, we have to see the cost effectiveness for the patient also.
Okay. So, ma'am, we
And,
have.
and another thing is the TBS you can do in the just patient is coming, you are doing it. But for MRI now, the time is also important. We have to send them to a center. There they will take lot of time. They will take out the picture, then they will assess. That also takes a lot of time. But in TBS, there is not much time. So I think the TBS is better.
Okay, ma'am. So, ma'am, we have one more question, ma'am. Like, how to evaluate hemorrhagic ovarian cyst to confirm endometriosis, ma'am?
See, hemorrhagic endometriosis, endometrial cyst, there are many figures in that also. Like first, we have to find out if it is right or left. Transvaginal scanning is the best. In the interior of the ovary, we can see three types of things. One is either it may show a level of fluid and blood clot. Second is it may show some strands within it. When we put probe movement, the strands will be moving here and there. Then only it is hemorrhagic, and we should wait for 2 months. If after 2 months, normally after giving the contraceptive pills, it should disappear. Then it comes under the category of hemorrhagic cyst. The endometriotic cysts are normally having ground glass fine internal echoes within it, and it doesn't disappear. So it is, you can, and endometriotic cyst, when we do the this Doppler, lot of supply around it, even within it also. So that also differentiates the hemorrhagic cyst from endometriotic cyst.
Okay, ma'am. Thank you, ma'am. Ma'am, I don't find any other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am. So if there is any queries, then we will mail it to you, ma'am. You can address those queries through mail also, ma'am.
Thank you, thank you.
Yeah, ma'am. Thank you very much once again for being with us today, ma'am. You have spent your valuable time with us today, ma'am. Thank you for the opportunity, ma'am. It was an honor to hear you once again, ma'am. Ma'am, and we are also planning for many more webinars in future with you, ma'am. And we need your support for making our Shield Connect page to reach. It's a platform for the new learners also, ma'am. The young budding doctors also will be watching our videos, and the videos will be available in YouTube, ma'am. You can share with any of your students also, ma'am, for their learning purpose, ma'am. Thank you, ma'am. Thank you once again. I thank you, audience, for their active participation, and also thank my team for making this webinar possible, ma'am. Thank you, ma'am. Thank you very much.
Thank you very much. Thank you.